And starting with the basics, we are going to have the next topic is risk factor and preoperative assessment by Dr. Vipul Arora.
So, good afternoon, everybody. At the outset, I would like to thank AIOS and Dr. Vinod Arora, sir, for giving me this opportunity. I shall be presenting my talk on risk factors and preoperative assessment for emetropia and cataract surgery. I have no financial disclosures for this presentation. I shall be focusing on the following points in my presentation, starting with patient counseling, ocular and systemic examination, ocular surface and dry eye disease, followed by biometry and astigmatism. Coming to newer modalities, fundus examination and OCT, and lastly, risk stratification system. Everyone wants perfect vision from cataract surgery, but we should try to keep patients' expectation at practical level and follow the mantra of under promise and over deliver. Whatever we do in cataract surgery, there is always some level of compromise, as we still do not have a perfect IOL that matches natural lens of a 20-year-old patient. So it is our job to figure out which compromise suits best to the patient. If we look at the benchmark standards for cataract surgery, we see 55% of patients are within half a diopter of target and 85% are within one diopter of target refraction. That leaves about 15% of the patient that are still outside one diopter of intended target, so there is room for improvement there. Generally, every hospital has team of preoperative workup which consists of optometrist, counselor, PRE apart from operating surgeon. Every patient who has come for cataract surgery also need a dedicated time and attention to know the expectation and lifestyle of the patient and also to make him understand what is best that can be offered to him. In examination, like always, as most clinicians will do, always examine both eyes at same time. It should not be only for visual acuity, but also for all parameters at same time. We should we should also not forget to take history of any prior ocular surgery or any history of blunt trauma to avoid any surprises during surgery. Preoperative evaluation begins with good history taking. History of drug tamsulosin, which is an alpha blocker, can cause floppy iris syndrome. Aspirin and warfarin can be continued if INR is in therapeutic range. Apart from routine blood pressure and sugar, we check ECG and oxygen saturation for all patients of cataract surgery. Viral markers are must for any surgical procedure. Lead and tear film examination is most underrated examination in cataract surgery. A study by Lucas et al. Have shown 59% of patients posted for cataract surgery had blepharitis. We should always try to look for any stye, lesion, or lid retraction in the eye and should also examine the tear film by tear film breakup time or Schirmer's test. Good slit lamp examination is cornerstone for cataract surgery. It helps us to rule out any other ocular comorbidity and also help in making risk stratification plan. It helps to preempt any intraocular complication during surgery and be better prepared for it. Spend few extra minutes to look for any corneal scar, prior LASIK or RK cuts, corneal gutted, fine old KPs. Size of pupil is important, then grade of cataract, whether it's a posterior polar cataract, subcapsular cataract. It helps in managing the case more efficiently. We'll talk about fundus in next few slides. Dry eye is almost everywhere. It is one of the most common thing that we see in our general practice, but sometimes we are so focused on cataract that we might overlook this issue going on in our patient. This can be debilitating condition for many patients and it really affects our outcome. It is really frustrating for a surgeon and that after doing a perfect surgery, patient is 6'6", they still feel that surgery is a failure because they are struggling with irritation and dry eyes after surgery. They consider it as our fault as this irritation was not there earlier. There is a landmark study called Prospective Health Assessment of Cataract Patients' Ocular Surface, or popularly known as FACO study, that looked into the incidence of dry eyes in cataract surgery. In this study, 63% of patients had tear film breakup time of less than 5 seconds. 77% had positive corneal staining. Schirmer's score was low in 21.3% of cases. And only 22% of these cases carried an established diagnosis of dry eyes. So, still 78% of the patients are undiagnosed case of dry eyes who presented for cataract surgery. There is another study by Dr. Priya Gupta regarding same, and they have found that 57% had abnormal osmolarity in tear film and 40% had positive corneal staining. We have lot of different tests to assess ocular function. It's better to be consistent with one or two tests and do it regularly in all the preoperative patients screening along with clinical examination. There are a lot of different symptoms that patient can manifest in many different ways for dry eyes, which we see here. Standard patient evaluation of dryness questionnaire, or the speed test as popularly known, it's a modification of ocular surface disease index questionnaire, and it's a way of knowing the status of ocular surface. We also have to take into account ocular and systemic medications and systemic conditions that can impact the ocular surface. Mammography is a new and efficient way of detecting and treating mammalian gland obstruction in patients for cataract surgery. Like in this example, we see a 68-year-old female with history of dry eye disease and LASIK surgery who presented for cataract evaluation. Her dry eye disease was causing poor quality of topography, irregular Myers, and also astigmatism of a pseudocylinder of around 2.37 diopters. But after treating the dry eye disease, the topography showed more regular Myers and there was resolution of pseudocylinder. So, a bad ocular surface can lead to unreliable biometry, foreign body sensation after cataract surgery, chances of infection, and delayed rehabilitation. A tear film is the most important refractive surface. Optimizing it leads to more accurate measurements, more predictable healing, and overall improved outcome. Treatment is by thermal pulsation, immunomodulators, lid scrubs, but we should remember that we should delay the surgery until the ocular surface is stabilized. Specular microscopy should be done when we suspect clinically poor endothelium. There is a risk of corneal decompensation when the count is less than 1000 cells per cubic mm. Coming to biometry, its a topic will be separately covered. I will just highlight few important points. We all use immersion biometry in clinical practice, and it's an excellent tool to calculate IL power in normal range of axial lengths. And this has also been proved by studies. But since all the major guidelines on cataract now recommend optical biometry as a method of choice, but as it is a method of choice, it is helpful tool for refractive cataract surgery. It gives refractive axial length as it measures the center of macula. It also incorporates the actual thickness of retina. It is operator independent, repeatable, and precise. However, like in cases of dense cataract or where patient is unable to fix, we may need to go back to immersion biometry. It's based on optical biometers are based on various principles. Most commonly being used is swept source OCT based, and there are newer advances in this. Third generation formulas are used with immersion biometry, whereas fourth and fifth generation formulas are used with optical biometer. But if we want to use a fifth generation formula with immersion, we can go to various websites like ASCRS websites, which provide free calculation on these formulas. Another important aspect is astigmatism. 47% of cases who presented with cataract surgery had more than one diopter of astigmatism. There are multiple ways in which key reading can be taken, and there are additional topography is also available if we are not unsure, if we are not sure about the axis. I usually take an auto K reading and confirm it with an optical biometer, which is more reliable than above. To confirm the axis, or in case of any doubt, one can use a pentacam. I usually refer my patient to my colleague if I have to use so. Coming to newer modalities, to further refine our results of refractive cataract surgery, multiple machines are available, and in industry we realize that there are so many diagnostic machines, and all trade fairs are completely full of newer machines. Now it lands on to us to understand which works best for us. In this, there are two, like corneal topographer and corneal tomography. Corneal topography measures the anterior corneal surface like OP scan or NIDEC OPD scan, whereas tomography is a 3D image of cornea, and it measures the anterior and posterior surface like pentacam. The major use of topography is in refractive surgery, post surgery astigmatism, surgical planning in cases with astigmatism, and also incision planning sometimes. These topographers again are based on various principles, most commonly used being Schemfeld based principles like Pentacam or hybrid topographer or OCT based topographers. Abrometer is another investigation that has gained attention, especially in premium IOL practice. It measures the higher order aberrations of cornea as well as of whole eye. It is also useful in dysfunctional lens syndrome as well as to measure angle alpha for multifocal IOLs. So, if we have a high volume cataract practice, we should go with either a topographer with a abrometer like OPT3 scan or eye trace, or we can go with topographer and a biometry like Anterion or a Pentacam AXL. A dilated fundus examination with high specificity but low sensitivity, and it is considered standard of care for macular evaluation before cataract surgery. In presence of cataract, its sensitivity reduces, so we cannot diagnose properly all the cases. And so is OCT helps us in these cases, but currently it's not used for all the cases, and it's only used for premium IOL practice. In a recent study by V. Lettel in JCRS 2021, macular pathology was detected in 40.6% of cases who had a normal fundus, normal macular in examination. And out of these 26% cases, the management was modified and in the form of intravitreal injection, laser, or surgery before cataract. Like in this example, we have vitreomacular traction, but again, the clinical examination fundus is normal. OCT shows VMT. In this case, in a high myope case, there is flattening of foveal contour, foveal thinning, but again, fundus is normal. And in this case, we have a mild ERM. So, the role of OCT is to detect overlooked macular pathology and better assessment of macular abnormalities. It helps in a better informed consent process and realistic patient expectation. B scan is done when we cannot visualize the posterior segment in dense and mature cataracts to rule out RD, vitreous hemorrhage, intraocular foreign body. Coming to last, the risk stratification system. It's a very good tool if incorporated in one's practice. It is especially helpful in meaningful counseling and what to expect after surgery. It also helps to alert regarding unusual intraoperative events and allotment of cases in teaching hospitals. Again, in this case, a study by Muntasib in BMJ 2004, it's a landmark study for risk stratification. And these points are allocated to risk factors depending on weightage of each risk factor in peer-reviewed literature. There are three categories allotment of the points or score per risk factor. Like in category B, each thing earns 1 point, whereas in category C, it earns 3 points. And so, based on the cumulative score, surgical patients is grouped into one of the four groups. Group 1 having no risk factors and group high risk factors. So, the complication increases from group 1 to group 4, and overall complication rate in group 4 is much more. And so, to summarize, a systemic and comprehensive examination consists of patient counseling regarding realistic expectation, identifying ocular comorbidities, a precise perfect biometry, appropriate incorporation of neurotechnology, and developing a risk stratification system. And it helps us achieve not only 2020 but a 20 happy patient. Thank you.
Thank you so much for an excellent talk, Dr. Vipul. I think there's, I can't say there's, one has to do the thorough examination. That's a must for systemic and eye also. And going next to is you have to have accurate IOL power calculation. That's the backbone of cataract refractive surgery. And on this accurate biometry, we have none other than Dr. C. M. Wavikar with us. Dr. Wavikar is an authority on biometry. He'll be giving us a lot of tips. So I think Dr. Vipul made a valid point. You have to look for the ocular surface first. That is not to be neglected. You have to look for the comorbidities also. Because nowadays we are not getting patients who don't have comorbidity. Getting a clean cataract case is becoming rare these days. Most of the patients have some sort of problem. They are taking some medicines or something. So we have to have a very good history of what is systemic illness, what the medicine is taking, any family history. Like these things, we had to be do a thorough examination of the face, eyes, and fundus also. Whatever the instruments you have, it's good. But even with minimal instruments, you can do a very good evaluation of the patient. Even with a simple slit lamp or even with a simple keratometer, you can give accurate results. Most of the biometries now are available with the SIL calculator. They are available online also. So you can use a simple biometer also to get a good result with these conditions.